CE Conversations, a clinical podcast presented by creative educational concepts designed to improve clinician performance and optimize patient outcomes. This session, Navigating Novel Terrain in Anemia of Chronic Kidney Disease, a patient-centric review of disease state, current chasms in care, and the future promise of HIF-PH inhibition, is accredited for 1 hour of ACCME, ANCC, and ACPE credit, and supported by an independent educational grant from GlaxoSmithKline. To earn CE credit for this activity, please visit the link in our show notes to complete the post-test and activity evaluation at the conclusion of the podcast. And with that, we'll turn it over to our expert faculty.
Welcome, everyone. Today's presentation is Navigating Novel Terrain in Anemia of Chronic Kidney Disease, a patient-centric review of disease state, current chasms in care, and the future promise of HIF-PHI inhibition. This presentation is presented by Creative Educational Concepts, LLC, and supported by an independent educational grant from GlaxoSmithKline, or GSK. My name is Dr. Ajay Singh. I'm a nephrologist at the Brigham and Women's Hospital and at Harvard Medical School. This slide now shows you our learning objectives. These are: review the prevalence and pathophysiology of anemia of chronic kidney disease, or CKD, emphasizing the multifaceted patient-centric burden of disease. Evaluate potential causes of CKD anemia under diagnosis and under treatment, and propose adaptive, evidence-based solutions to optimize care. Appraise current clinical controversies in the management of CKD anemia, highlighting the safety concerns posed by erythropoietin-stimulating agents, ESAs, and discuss how these challenges have prompted the need for novel therapeutic approaches. Examine hypoxia-inducible factor, HIF, as a key pathophysiologic component and a novel treatment target in CKD anemia. Summarize the expanding clinical trial, evidentiary base, and regulatory landscape for HIF-prolyl hydroxylase, or HIF-PHI inhibitors in CKD anemia management. And last but not least, use a practical case-based format to design individualized and multidisciplinary treatment plans for patients with CKD anemia that are safe, effective, and promote equitable solutions to healthcare disparities. Let me now turn to Dr. Jane Davis, an esteemed member of our faculty, to present on characterizing anemia of CKD, a deep dive into pathophysiology, patient burden, and causes of undertreatment. Dr. Davis.
Thank you very much, Dr. Singh. So we are going to discuss in somewhat detail how patients become anemic, the burden of anemia, and some of the causes and reasons for undertreatment, as well as potential treatments. We know that 15% of American adults, which is approximately 37 million people, have chronic kidney disease. Anemia is more prominent in CKD, about 15.4%, than in the general population. In fact, it is approximately double that. If you look at the graph at the side, you will see that over the years, the number of patients or the percentage rather of people who have CKD has risen and declined, and it has right now it's fairly stable. However, it should be noted that those patients, particularly those in stage 2 and 3, who are the purple and the green lines, I'm going to do that one over. Is it a gray line? It's a gray line. Okay. Do that over, please. 15% of American adults, which is approximately 37 million people, have CKD. Anemia is more prevalent in patients with CKD. In fact, it is approximately double that of the general population, 15.4% compared to 7.6%. Anemia in CKD is undertreated because it is underdiagnosed, and the treatments are underutilized, even using the appropriate lab values. CKD anemia is associated with an increased risk for adverse kidney and cardiovascular outcomes. Looking at the graph at the side, it shows you the approximate percentage of patients with different stages of CKD over a period of time from 1988 to 2016. It should be noted that those patients in stage 3 and 4 have the highest incidence and likelihood of progressing. And as they progress, their chances for developing anemia also increase. The prevalence of anemia stratified by GFR illustrates this. According to KDOQI guidelines, anemia is hemoglobin less than 13.5 grams per deciliter in males or less than 12.0 grams per deciliter in females. And as you see by the slide there, the number of patients whose hemoglobin is less than 12 grams per deciliter, which would be considered anemic for both males and females, dramatically increases as the stage of CKD progresses. We also know that patients with CKD are more likely to die before they need renal replacement therapy. The highest risk for patients are those with multiple comorbidities, anemia being one of them. So outcomes of anemia and CKD. Anemia is associated with several poor outcomes. There is a decreased health-related quality of life. Patients who are anemic lack energy. If you don't have energy, it is difficult just to get through the task of daily living, much less participating in other activities that you may enjoy. These end up increasing isolation and taking away from social time, which is so important for our emotional and mental health well-being. Anemia also increases cognitive issues and can cause declines in mental health from depression and lack of ability to participate in activities. There is an impaired functional capacity. Again, if you barely have enough energy to get through the day of what you need to do, it is very difficult to have the energy to do what you really want to do. We also know there is an increased hospitalization and cardiovascular disease mortality that is associated with anemia. Patients who are anemic have an increased risk of renal and major cardiovascular events. I'm not going to review the slide to the right, but you can see the proportion of events with patients as goes through their stages. We know that as patients' kidney disease progresses, they are higher risk for a number of comorbidities. This slide is very detailed, but if you study it, it really tells you just about everything that you need to know about anemia and the relationship between erythropoietin, or EPO, and hepcidin and the liver and the kidney. We know that erythropoietin is produced by the kidney, and as kidney function declines, the production of erythropoietin likewise declines. As that production declines, there are fewer red blood cells made, and with fewer red blood cells, we have increased risk of anemia. So with anemia and CKD, you have a decreased response to hypoxemia, and therefore the erythropoietin, or EPO, production is decreased, which leads to, as I said, a decreased production and lifespan of red blood cells. The normal red blood cells lifespan is approximately 90 days. It is less than that in patients who have CKD and decreases as their CKD progresses. Iron availability and utilization of iron due to either functional or absolute iron deficiency. Also occurs as anemia progresses. Hepcidin, which is produced by the liver, is increased in inflammation. Hepcidin then prevents iron absorption from the GI tract and iron liberation from macrophages. And as we will see, it is essential to have iron to have healthy red blood cells. So we talk a lot about inflammation in CKD anemia. When we talk to our patients about inflammation, they generally think of an infected sore or a red spot, but there is a good deal of inflammation that goes on internally. 30 to 50% of end-stage kidney disease patients, also referred to as ESKD, demonstrate active inflammation. This can be measured by an increased C-reactive protein, or CRP, and an increased ferritin. It is usually accompanied by a decreased albumin. There are multiple causes: cardiovascular disease, diabetes, infection, ulcers, both of the skin and oral. Poor dentition contributes, malnutrition, arthritis, oxidative stress. Just having chronic kidney disease is a source of inflammation. And as the disease progresses and patients become more uremic, this too becomes a source of inflammation. We cannot emphasize enough how important it is to recognize this contribution of inflammation to CKD anemia. There is strong evidence supporting the role of inflammation, which then leads to increased hepcidin in CKD and CKD anemia. Treatments that have been investigated include anti-cytokine therapies, statins, cholecalciferol, and sevelamer. Dietary interventions sometimes are helpful. And in patients who are on dialysis, particularly hemodialysis, altering their prescription may be beneficial. However, we don't have any hard evidence for any of these treatments, and we do need more study. The first step in evaluating anemia is to check the blood work. Unfortunately, in many areas, the hemoglobin and iron indices are not measured as frequently as the guidelines recommend. The commonly used tests that should be ordered to evaluate iron deficiency of anemia include the serum ferritin, the transferrin saturation, also called the TSAT. A complete blood count is also critical. This includes the hemoglobin concentration, the RBC indices, the white count and differential, and a platelet count. In addition, serum vitamin B12 and folate levels should also be checked. When we refer to iron deficiency in CKD anemia, we are talking about either functional or absolute. Functional iron deficiency means that there is a low availability of iron to utilize. We will often find TSATs that are less than 20 and ferritins that are greater than 100. In dialysis patients, it's greater than 200. An absolute iron deficiency is a reduction both in the available and the stored iron. So your TSAT will be less than 20 and your ferritin less than 100 or 200. The first step in treating anemia is to have adequate iron stores. And we have two options in most cases. We can supplement the iron with oral tablets, or we can do IV iron. The oral should only be considered in non-dialysis dependent CKD. IV iron is beneficial for most patients with CKD and is definitely preferred over oral iron for dialysis-dependent CKD. Studies have shown that iron levels that are kept at a normal and adequate level will reduce overall cause of death, non-fatal MIs, strokes, hospitalizations, and can reduce ESA dependency. IV iron has also been shown to benefit patient outcomes, particularly in patients who have heart failure with reduced ejection fraction, whether they have CKD or not. Oral iron, on the other hand, which is used for your non-dialysis patients, is less invasive, but it is less effective. Patients often complain of GI upset. There is poor absorption, and it is much less predictable. Individual treatment is crucial after diagnosis of CKD anemia, and management may include blood transfusions, ESA therapy, oral or IV iron. The guidelines indicate that the ESA therapy should be targeted to reduce the incidence of blood transfusions. And now I will turn the program over to Dr. Singh.
Well, thanks very much, Jane. That was a really nice overview of CKD and CKD anemia and some of the issues. Let's now discuss a case, and joining me in addition to you is Dr. Calvin Meaney. Welcome, Calvin. Let me read the case. This is an introduction to HB. HB is an 80-year-old female from Geiger, Alabama, who presents for an annual physical by her primary care physician. She has not seen her PCP for several years, having missed multiple appointments because of difficulties with transportation. She says she feels fatigued and unable to do a normal task. She has a small foot ulcer on her right heel that is not improving. She thinks that she stepped on a stone in her backyard 6 weeks ago. The patient lives in a rural area, approximately 50 miles from Tuscaloosa. She's widowed. She has a brother who lives near her and a daughter who lives in Atlanta, Georgia. HB's history includes type 2 diabetes mellitus with a hemoglobin A1C measured 3 years ago of 8.6% and poorly controlled hypertension with a blood pressure last measured 3 years ago of 165 over 80 millimeters of mercury. Her serum creatinine, also measured 3 years ago, is 1.2 milligram per deciliter. Current medications include metformin, 500 milligrams twice a day, glipizide XL, 5 milligrams once daily, valsartan, 80 milligrams twice a day, amlodipine, 10 milligrams daily, aspirin, 81 milligrams daily, and atorvastatin, 20 milligrams once daily. Examination shows an elderly, frail African-American woman, a blood pressure of 160 over 80 millimeters of mercury, a heart rate of 70 beats per minute, and a BMI of 34 grams per meter squared. She's afebrile. She has 1+ lower extremity edema bilaterally and a shallow right heel ulcer. Laboratory data shows a urinalysis of 1% protein that's negative for blood, a serum potassium of 4.2 milliequivalents per liter, a serum creatinine of 1.7 milligram per deciliter, and eGFR of 43 mils per minute per 1.73 meters squared by the CKD epi equation, a hemoglobin of 9.3 grams per deciliter, a white count of 6.9, a platelets of 262, and a hemoglobin A1C of 8.2. She's been diagnosed with stage 3 CKD using the NKF classification system. So let's, let me just pause here. Goran, is that okay? We can edit this little thing when I advance the slide. Would that be okay?
Yeah, definitely.
Yeah. So I'm going to now turn to the questions, right? So, so let me turn now to my colleagues, Dr. Jane Davis and Dr. Calvin Meaney. Jane, let me ask you this. In this patient who has stage 3 CKD, what do you think the likely causes are of her chronic kidney disease?
Well, she has diabetes, which is not well controlled, and she also has blood pressure, which is above the goal of less than 130/80. She also has a number of social issues, more than likely. She has difficulty obtaining transportation, so we have to consider that she probably has somewhat of a hard time getting nutritious food to eat.
Great, thank you. So you're right. So she clearly has a high likelihood of diabetic nephropathy with complications, right? So the idea that she has proteinuria, abnormal kidney function, she has this foot ulcer that's probably a source of significant inflammation, probably related to her diabetes. And as you pointed out, she has poorly controlled hypertension. The other interesting point, I guess, is that none of this is really contemporaneous. Many of these measurements were, or all of these measurements were done 3 years previously. So that's a real issue. But even 3 years ago, back then, these were poorly controlled. Hypertension, diabetes, among two of them. The issue of poor access to care is clear. I mean, she's definitely lives in a relatively remote area. She doesn't have a lot of support. I mean, granted, she has a brother who lives nearby, but clearly some challenges with getting to her appointments and getting labs drawn. And while we don't have a good sense of what the socioeconomic factors are, I think you'd agree that given the fact that she's African American, there may be some issues with related to social determinants of care and access related to race that may also be playing a role. But I think the other point you made, which I think is a good one, is that perhaps if she is indeed if indeed she has problems with socioeconomic status, she probably is not having the sort of ideal nutrition that's rich in foods containing iron. So I think that paints a very rich picture of what the issues are here. Let me turn now to Calvin. Calvin, she has anemia. Could you discuss with us what you think the causes are and how would you work this out?
Yeah, I mean, I think it's important to think about that multifactorial pathway that Jane nicely presented. Certainly we would be worried about a relative erythropoietin deficiency in a patient with moderate chronic kidney disease, and that's likely a main contributing factor here. But the other is going to be iron deficiency, and that kind of links to that initial workup. So we don't have an iron panel or an iron laboratory assessment for this patient at this point, and that would really be the first stage of the workup to determine if she has an iron deficiency, either an absolute or a functional iron deficiency. And she may be at high risk for this, as we mentioned, because of nutrition, but also because of her degree of inflammation. So not only a heel ulcer, which can certainly contribute to inflammation, but history of things like diabetes and now CKD diagnosis are all associated with chronic inflammatory state. And that is really going to increase her hepcidin and decrease her ability to absorb and utilize iron, which can certainly contribute to her anemia. And so for the workup, as mentioned, an iron panel, so another laboratory assessment, should also look at other cofactors that are important for red blood cell production, such as folate and vitamin B12. And a fecal occult blood test of her stool would also be useful to rule out any occult blood loss sources.
Great, thank you. Clearly, her hemoglobin is less than 10, and as most people appreciate, the FDA guidance and many of the guidelines that are out there, of course, some that are a bit dated now, suggest that one should start treatment in patients when the hemoglobin falls below 10 grams per deciliter. But one of the things that hasn't really been discussed and is not prominent in this case description is our iron status. Calvin, what are your thoughts about that? And I know we're going to talk about iron in the next segment, but how do you position measurement of iron status sequentially in the workup of someone who's anemic and who might require replacement with an ESA?
Yeah, I mean, that's a great question. So, it really should be the first thing on our minds when we're working up anemia in these kidney disease patients, because the first step of treatment is going to be repletion of an iron deficit if one does exist. It's critical if you're considering starting an ESA to ensure that the patient is iron replete beforehand so that they have that sort of substrate to make the new red cells that ESA is going to stimulate. And so it really is a critical first step in our workup of these patients.
And this is a complex patient scenario, very realistic, I guess, because we don't get simple, straightforward patients to take care of. And Jane, you know that because I'm sure you see lots of patients just like this who have complexity, not only in their comorbid conditions, the fact that they may have both iron deficiency and ESA deficiency and an inflammatory focus, but beyond that, all the social determinants of care that ultimately will determine how she's going to access the therapies and how the follow-up is going to occur. So I think this has been a really nice summary, and I think the Q&A brought out some important teaching points. Let's move to our next presentation. And here we're going to talk about where we've been and where we're going, overcoming obstacles to optimal outcomes with HIF-PHI inhibitors. And to present this for us, we have Dr. Calvin Meaney, who's already been introduced. Dr. Meaney, take it away.
All right, thanks very much, Dr. Singh. So as Dr. Davis started to mention at the end of her section, we really have three major treatment options for our current standard of care in anemia of chronic kidney disease. The first, as we discussed, is going to be iron, either oral or intravenous. And we want to make sure that we're correcting our iron deficiencies before using an erythropoiesis-stimulating agent or an ESA. So the ESAs are typically added on to iron treatment or used in patients who are already iron replete. And this, as we've discussed, addresses their relative erythropoietin deficiency. But thinking back to that multifactorial pathophysiology, it really doesn't affect all of the other components that are contributing to anemia of chronic kidney disease in these patients. The option we reserve for the last line is going to be a red blood cell transfusion. And really, when you think about what your goals of treatment are in anemia of CKD, the first goal is to avoid or prevent the need for red blood cell transfusions. And this is because they increase the risk of allosensitization, which can lead to poor kidney transplant outcomes. If these patients' kidney diseases progress towards kidney failure, the ultimate treatment there and the best treatment is going to be a kidney transplant. So we want to set these patients up for success of that kidney transplant. And avoiding red blood cell transfusions is the best way to do that. In the non-dialysis chronic kidney disease space, anemia is quite prevalent, as we've seen. However, the treatment of it is very poor. So less than 40% of treatment, less than 40% of patients rather, receive treatment for their anemia, again, in the non-dialysis population. And unfortunately, the most common treatment option here is going to be that red blood cell transfusion. So the one we want to try to avoid is the most common option that gets used in these patients. And I think this really highlights that unmet need in our current standard of care. So we're not utilizing these iron and ESA treatments well, in particular in our non-dialysis patients, which leads to a lot of last line treatment options. So how do these treatments fit into the KDIGO guidelines? So the last guidelines here were in 2012. And so they really emphasize iron supplementation when an increase in hemoglobin or a decrease in ESA dose is desired, and the transferrin saturation is less than 30 and the ferritin is less than 500. Intravenous iron is going to be preferred in our hemodialysis patients. This is really because oral iron has minimal bioavailability in a hemodialysis patient. They have so much inflammation, so much excess hepcidin that they really don't absorb any oral iron. However, in the non-dialysis CKD patients, we could consider a 1 to 3 month trial of oral iron, depending on their severity of iron deficiency and severity of anemia. The ESAs should be used to achieve a hemoglobin that doesn't exceed 11.5. This is per the KDIGO guidelines. In the United States, the FDA product labeling limits this upper threshold of hemoglobin to really 11 in our dialysis patients and around 10 in the non-dialysis population. And it's recommended to start those ESAs, again, once iron replete, as the hemoglobin is in the 9 to 10 range in our dialysis patient population. So it's important to note that these guidelines are a decade old, and they're actually currently being updated. So I would expect to see the updated recommendations out in the next 1 to 2 years from KDIGO. So some of the barriers to using ESAs that lead to that undertreatment, particularly in our non-dialysis population, are that all of our ESAs are injectable medications. They can be given subcutaneously or intravenously, but they do require an injection, which if a patient is self-administering, can sometimes be a barrier for patients to adhere to that particular medication. These drugs are all stored and transported in refrigerated temperatures, and any excursions above or below a very narrow temperature range can lead to stability problems, and medication would need to be not administered if it falls out of a cold chain, either in transportation or in patient storage at home. And so that can as well be a barrier to patient use of these medications. As mentioned, there's a very narrow target of hemoglobin when using ESAs, depending on the patient population, and that requires frequent laboratory monitoring and frequent dose adjustments, which may be difficult for patients to adhere to. And then there are some unique safety concerns to our ESAs that also may be viewed as potential barriers to their use. So these safety concerns come from a number of clinical trials in the 2000s that were comparing a higher hemoglobin target, near normal hemoglobin in our chronic kidney disease anemic patients, to lower hemoglobin targets. And these trials were the normal hematocrit trial, the acquire and create trials, and then the treat trials. And what they showed consistently were that targeting a higher hemoglobin or a near normal hemoglobin was associated with worse cardiovascular outcomes, increased risk of stroke, a worsening hypertension that appears to be a dose-dependent phenomenon, and an increase in the risk of thrombotic events. And of particular concern here are vascular access thromboses in our dialysis patients. For the hemodialysis patients, that access is their lifeline to dialysis, and if it clots off, that can have significant implications for their care. And so it's important to note that while these are serious and very concerning adverse effects, they're mostly associated with a higher hemoglobin target, and that's why a lot of our hemoglobin targets have shifted down since the results of these trials have been released. It's also important to note that subsequent analyses of these trials have looked at other factors that may be associated with these safety concerns. And some of those include the rate of change of hemoglobin, so rapidly increasing hemoglobin may also impart a risk, as well as the ESA dose. So those patients that required a higher ESA dose to achieve the target hemoglobins were at a higher risk of the cardiovascular and thromboembolic complications here. And so while it's not necessarily any one of these factors, more likely a combination thereof, it's important to take those into account when selecting and utilizing an ESA for the treatment of anemia and CKD, and really sticking to the target hemoglobins for those populations, and conservative dose adjustments that achieve a slow and steady increase in that hemoglobin. So hopefully I've emphasized that there's really an unmet need for treatments of anemia in chronic kidney disease. An ideal treatment would be one that targets that multifactorial pathophysiology. It addresses elevated hepcidin, and it addresses inflammation, and it addresses erythropoietin deficiency, iron deficiency. And they would have orally available options, and minimal dose adjustments and dose monitoring rather of hemoglobin levels. So a potential class of medications that fit some of those criteria, though not necessarily all, are what we now term the hypoxia-inducible factor prolyl hydroxylase inhibitors. It's a mouthful, I know. You'll see this abbreviated in our presentation as HIF-PH inhibitors. They're also called HIF-PHIs and sometimes HIF stabilizers, so we have different terms for them still. What the hypoxia-inducible factor, or HIF pathway, is a normal physiologic pathway that responds to either a normal oxygen environment or a low or hypoxic environment. And so the figure here on the left is showing HIF alpha subunits, which are kind of in green in the middle. And at the top, we have a normal oxygen environment, and where we see a lot of these HIF prolyl hydroxylase enzymes surrounded by that nice blue oxygen. So in the setting of oxygen, these prolyl hydroxylase enzymes degrade HIF alpha, and it gets out of the cells, and we don't use it, right? So we don't stimulate this HIF pathway. However, near the bottom of this figure, we can see a hypoxic environment where there's not a lot of oxygen around, and these prolyl hydroxylase enzymes don't degrade HIF alpha. And so then HIF alpha is able to dimerize with HIF beta that gets into our nucleus and stimulates the transcription and subsequent translation of erythropoietic genes. And so this leads to a more physiologic erythropoiesis response, where we get an increased production of endogenous erythropoietin, increased erythropoietin receptor expression, probably indirect suppression of hepcidin, increase in iron availability through increased iron transporters, as well as increased transferrin. And so this is, again, a more complete erythropoietic response, where we're targeting multiple pieces of that pathway that becomes aberrant in our chronic kidney disease patients. So we can exploit this pathway pharmacologically by using a medication that would inhibit these prolyl hydroxylase enzymes. And that's what's simulated here in this figure at the top, where they're showing prolyl hydroxylase inhibition in the normal oxygen environment that allows for HIF alpha stabilization, dimerization, translocation, and then upregulation of those erythropoietic genes. So by giving a HIF-PH inhibitor, it leads to enhanced endogenous erythropoiesis, as well as increased iron absorption, as well as iron utilization. So it's nice in that it targets multiple pieces of that pathway. So those things that I just mentioned are shown here on the left. These are some of the potential beneficial effects in anemia of CKD. It's important to remember, though, that the HIF pathway regulates more than just erythropoietic response, and overstimulation of that HIF pathway may lead to some potentially undesirable effects. Malignancy, retinopathy, gastrointestinal erosions, thromboembolism, and hypertension are all theoretical concerns. These would be concerns of, again, an unregulated stimulation of the HIF pathway, which really doesn't occur with most of these HIF-PH inhibitors that are in development. They're more of an on-off switch. They can turn the pathway on, and then it turns off after the drug wears off for some period of time. But again, these are important potential safety concerns to keep in mind as we review some of the clinical trial results for these HIF-PH inhibitors. So there are currently 6 HIF-PH inhibitors in the regulatory pipeline. Those are roxadustat, vadadustat, daprodustat, melidustat, decidustat, and erythropoietin-stimulating. So you can see they all end in dustat. So it's the suffix of these generic drugs. The 6 of them are at different phases of regulatory development. So roxadustat and vadadustat have actually submitted new drug applications to the US FDA, and both have had complete response letters in response to those new drug applications. We'll talk about some of the safety data that led to those complete response letters. Daprodustat has submitted their new drug application, and the expected decision is by early 2023. And the others are undergoing phase 3 trials currently. And so for the remainder of this section, I'm going to focus on those first 3 in this class, since they're the farthest along in the development pathway. So we can spend a lot of time talking about the hemoglobin responses in all these various clinical trials. But those results can basically be summarized in one slide, which is that they reliably increase hemoglobin in both our dialysis and non-dialysis populations. So in a number of these trials were non-inferiority trials comparing the HIF-PHIs to ESAs, and in those trials, non-inferiority criteria were met. When compared to placebo, particularly in non-dialysis patients, superiority criteria were met. So again, across the board of the different agents in different populations, they work, right? They increase hemoglobin, they do so reliably, they do so within a range that we can titrate to with various doses. And so we know from an efficacy perspective, these agents do work. Some concerns that have been raised, though, in their development has been on the safety side. And so this slide is showing roxadustat safety from pooled results of their clinical trials program. And they're looking at here major adverse cardiovascular events, so that MACE endpoint, which is all-cause mortality, non-fatal MI, and stroke. So in the left, here we're seeing a Kaplan-Meier curve of roxadustat, which is in the blue dotted lines, compared to placebo in the solid red lines. And this result shows MACE in what they call the on-study period. So this is looking at the entire trial period to the last follow-up that that particular patient had available, regardless of when the patient was on treatment or stopped treatment, switched from placebo to not placebo, whatever it was, the whole follow-up period, they showed non-inferiority for that ascertainment window. However, when you look at a different ascertainment window here on the right-hand side, we can see that there was actually a higher risk of MACE within the roxadustat treatment for a period of what they termed on treatment plus 7 days. So if you looked at just when these patients were given the drugs, the trial drugs, plus 7 days after, there was an increased risk with roxadustat. I mean, you're going to see these results for a number of the other agents, that the risk of adverse cardiovascular events is really dependent on the ascertainment window, as well as the medication that we're looking at in the patient population, whether it's dialysis or non-dialysis. So again, this is roxadustat for the non-dialysis population. Looking at roxadustat in the dialysis population, in that on-treatment plus 7 day period, it was a non-inferior MACE risk. However, in that on-study period, there was a slightly increased risk of MACE with a hazard ratio of 1.14. So there was concern for adverse cardiovascular events with roxadustat in both the dialysis and non-dialysis population. Again, varies a bit by the ascertainment window. There were some other concerns in the trial data, so some risk of vascular access thrombosis and deep vein thromboses, and that is likely what led to the FDA's complete response letter in response to the new drug application. So roxadustat currently not approved in the US for use. It is approved in Japan, China, the EU, Chile, and I believe South Korea. So it is approved in other areas of the world, just not the US currently. Vadadustat, again, in the dialysis population, its adverse cardiovascular events were non-inferior to ESAs. And however, in the non-dialysis population, there was an increased risk of MACE with vadadustat, and that was statistically significant. And so again, FDA issued a complete response letter in response to the new drug application here as well, likely related to these safety concerns. There's also mention of liver injury here, but those results weren't reported in the clinical trials. Daprodustat is the last one that's currently under review by the FDA. We can see that in the dialysis population, it was non-inferior in terms of its adverse cardiovascular risk. In the non-dialysis population, in the intention to treat, it was non-inferior. However, in the on-treatment, which was basically on-treatment plus 28 days, there was a signal towards an increased risk of cardiovascular events with daprodustat. There were also some other adverse events listed here, which were esophageal gastric erosions and cancer-related mortality that will certainly warrant some further investigation. So this is just showing kind of a summary of the adverse cardiovascular event risks with the different agents based on that ascertainment window and the particular population, whether it was dialysis or non-dialysis. And so really the take home is that it depends on the agent, the population, and the ascertainment window for where that adverse cardiovascular risk may represent itself.
Great, thank you very much. And we're now going to go to our patient case. So let me just pause for a second. Are we, Jane and Calvin, all set with that?
Yep.
Yes.
Goran, all set? I'm going to read the question, the case out, and then start the discussion. What are we doing for time? It looks like we are, this took a little longer, Goran. Are we okay with the discussion going on for 5 minutes, or should it be faster than that?
Did you say you have to hard out at 11 in 10 minutes?
No. I can go a little longer, but in
Okay.
terms of the activity time, how much time do we have for the third activity? Then I can factor in the Q&A accordingly.
I think I can always cut it short in post-production. So I would suggest you just deliver the message that you want to deliver, and then we'll work with what we have, you know.
Okay, great.
I think the interactivity between the three of you is going to be really key to part of this. So I would like to have as much of that as possible. And to Goran's point, we can always work on it post-production, or we can go a little over an hour if needed.
Okay. Yeah, I have a because of the time that was allocated, we might have to come back and do this. I have to give another talk online for about 20 minutes, but I have a bit more time after that. So I don't know whether there's a possibility of me introducing Dr. Meaney for the last section, and then there's a gap for 10 minutes, and then we come back and finish up the Q&A. I don't know. What are your thoughts on that? Or I could introduce Dr. Meaney, and then we could do the Q&A, and then he can record and I can take off. Does that make sense? And you can just
that would work better for me. Because I'm a push for time.
Okay. So let's try to do that. Is that okay with you, Goran? So I'll introduce Dr. Meaney's section. We'll pause. They'll go to the case, discuss the case, and then Dr. Meaney can have you guys do the presentation without me there. Is that okay?
Yeah, that works. So
okay. All right. Let's get started. 3, 2, 1. So let's now turn to patient case part 2. HB is initiated an oral iron therapy, iron sulfate for TSAT of 12% and a serum ferritin of 80 nanograms per mil. Her folate and B12 are within normal limits. Fecal occult blood is negative. Her CRP is 2.8 milligrams per liter, and her erythrocyte sedimentation rate, or ESR, is 42 millimeters per hour. So patient HB has blood work taken by her nurse with the Visiting Nurse Association, or the VNA, and is seen remotely by a telehealth visit 3 months later. She says that her fatigue has improved, though still persists. However, she has complaints of abdominal bloating, constipation, and has noticed her stool is black. Her foot ulcer, following more intensive local care by VNA, is improved, fortunately. Her labs show a hemoglobin of 9.8 grams per deciliter, a TSAT of 23%, ferritin of 110 nanograms per deciliter, and a potassium of 4.2 milliequivalents per liter. Her BUN is 36, and her serum creatinine is 1.7 milligrams per deciliter. And so we're now going to just turn ourselves to some questions, and let me just start that and invite Dr. Meaney to take the first question. So Dr. Meaney, her iron deficiency is clearly repaired. She was treated with oral iron. Do you continue the oral iron despite her repairing of the iron deficiency and despite her symptoms, or do you pause the oral iron therapy itself? Alternatively, do you stop oral iron and treat with another course of IV iron, or a course of IV iron only when she becomes iron deficient? What are your thoughts with that?
Yeah, that's a great point. I mean, this gets back to the sort of patient-specific decision-making that should occur here. So oral iron certainly worked for her in terms of the laboratory improvement of her TSAT and ferritin. Her hemoglobin also came up a little bit over that period of time, and her symptoms have improved, though they're not entirely resolved. So I think it depends on what the patient is viewing the benefits of oral iron to be relative to the sort of classic side effects that she's experiencing. So abdominal bloating, constipation, stool discoloration. These are the most common GI complaints that we hear time and time again with our oral iron products, and also why oral iron is very difficult for patients to adhere to. So if that side effect burden is becoming too much for the patient, at this point, I think it's okay if we were to take her off of the oral iron and continue to monitor her labs and her symptoms. And as you mentioned, if the iron deficiency then gets worse in the future, an course of intravenous iron could be considered, because she's already had a significant side effect burden from the oral iron. But it's important to engage the patient in this decision-making process and to educate her about the risks of continuing that iron, be it the recurrence of these side effects, and the risks of stopping the iron, and that her iron deficiency may come back and her symptoms of anemia may worsen. But because we have that IV option in our treatment bag, we could certainly use that in the future if needed.
Great, thank you. And obviously, there's controversy among both pharmacists and nurses and physicians, or the healthcare team, about the value of oral iron. Some people would say that it's not worth it, because in these patients with advanced kidney disease, iron absorption isn't that great, and you have to then settle with the trade-off or with greater side effects. On the other hand, someone like this who's going to have a hard time accessing intravenous iron, it seems like starting her on oral iron, and maybe there's be somewhat tolerant, healthcare providers be tolerant of some side effects, because at least we're getting to repair the iron deficiency. So I think there's clear controversy. Do you agree with that? I mean, it's not an open and shut case about oral iron.
Yeah, I mean, I certainly agree. And her kidney disease is, stage 3, so it's, moderate, but it's not to the so severe stage that, oral iron is going to have no absorption. That's where we worry more in the stage 5 in hemodialysis patients, where they really get minimal absorption from the oral iron. So she still certainly has some benefit from it, and it's currently treating her anemia well. So potentially continuing it, or considering some dose modifications where she takes it less frequently to minimize the side effect burden, but to still allow her to have that iron repletion may be beneficial.
Great. So let me just turn to another aspect of her care, and that she remains anemic and continues to be tired. Dr. Davis, what do you do here? I mean, what would you do in your practice with patients like this? Remains symptomatic and particularly tired. What are the next steps?
Well, let me just go back to what Calvin was saying. A concern of mine is, even if I tell HB to continue the oral iron, she's got complications. She is not going to continue it. So we can suggest she continue it. We can add a bulk laxative, and that may help, but I would be very doubtful she would continue the iron. I would initiate an ESA, which at least in our practice, we do as a weight-based protocol. And I would check her iron and her hemoglobin again in 1 month.
So, and how would you? What do you use in your practice? Do you use long-acting ESAs? Do you use short-acting? How do you think about the dosing of these? Because clearly the disparities are evident in this person, right? She's in a remote area. She doesn't have a huge amount of follow-up. What are you going to do?
Well, I would look at this patient and consider her socioeconomic environment. She has difficulty with transportation. She lives outside of Tuscaloosa, where I'm sure she could get the oral iron, but could she get there? She is obese. She has edema, so I know that her diet is probably not the best. I think the best course of action with this patient, and again, it has to be individualized, and the patient definitely has a say in it, but I would start her on outpatient 60 of a long-acting ESA. Now, we use the short-acting in our dialysis units, but in my outpatient clinic, we use the long-acting, except
that's the erythropoietin alpha, correct?
Yes, except for sickle cell patients.
Okay. All right, great, thank you. So I know, Calvin, you discussed the area of HIF-PHIs and touched on the opportunity for novel agents. But as we all agree, they're not approved in the United States, and we're not permitted to prescribe these agents. Although there are a number of places around the world, as you pointed out, where they are now available because they've been approved by the regulators. But let's assume that these agents progress in the regulatory cycle. Do you think that these agents fill an unmet need in the treatment of anemia?
Yeah, I think it's a great point. And when you look at a case like the one that we're examining now, it may be a patient here that's very well suited to be treated with an agent like a HIF-PHI. It can address that multifactorial anemia pathophysiology. It can help with their iron deficiency, iron utilization, erythropoietin production. These are orally available agents taken once a day or sometimes every other day. And so it fills a real unmet need, especially in a patient like this who has difficulty accessing care, has having side effects of our current treatment. So it offers them an alternative to an ESA, which is injectable, requires cold storage, is costly, and it may reduce her need of an oral iron as well. And so that benefits the patient from both of those perspectives.
And of course, the other point is, of course, that in someone here who has just the challenges with getting access to care and getting into an ESA clinic, transportation issues, socioeconomic issues, etc., having a prescription of oral medication, iron, and a HIF-PHI may be really quite beneficial. So there's an issue of competing risk here, right? The risk of maybe she's not as compliant so with an oral agent, but on the other hand, look at her history. She hasn't been following up with the visits, and she lives far away. The likelihood of her A, getting through the bottlenecks, and B, actually getting to an ESA clinic may be quite limited. Do you agree with that?
Yeah, no, I mean, I agree 100%. I think that's a great point. So that access to her care, her transportation issues, all those sort of social determinants of health that she's struggled with to access care in the past are going to continue to be a barrier for her. And so using a medication, such as a HIF-PHI, if one were available, could help to overcome some of those barriers.
Great, thank you. Thank you both. We're going to move on now to the next presentation. So this presentation is titled Multidisciplinary Momentum, Real-World Team-Based Strategies for Improving Care and Achieving Equity in CKD Anemia. And the presenter for this is Dr. Calvin Meaney. So Calvin, we're going to pause now, and then we're going to go to the last slide, the patient slides, and I'm going to read these. And then now let me ask Erin, do you and Goran, do you want me to also read the questions, the post-test questions, or that's going to come? Doesn't need to be read. Is that correct?
No, that doesn't need to be read. Okay. We're not doing that.
All right. So we're just going to go to the third. We're going to go to the third part of the case. Let me just make sure I have it here. All right. Okay. Let me just go to the Q&A. Hold on one second. Okay.
And don't forget to do a thank you slide at the end. Sort of, it's just a theme slide with the.
So just do I then after the discussion just do a thank you as well?
Exactly. So you have basically 3 slides to record. This one, the next one, and the third one.
Yeah. Got it. Okay. 3, 2, 1. Dr. Meaney, that was excellent. Thank you again. So let's move back to our case. This is part 3. HB is initiated on darbepoetin 40 micrograms every month, subcutaneously administered by her VNA nurse for the first 3 months. However, because of limited resources, the administration of subcutaneous ESA has been transitioned to self-administration, ideally supervised by her brother. Now, 9 months after HB's initial visit, the patient feels better and is not complaining of tiredness. Her foot ulcer is better. Labs during this time have shown continued stability in her renal function. She started on an SGLT2 inhibitor, dapagliflozin, 5 milligrams orally once daily. The patient's labs are checked again for this visit, and her hemoglobin is now 9.8 grams per deciliter. She has not been able to comply with regular administration of ESA every month, in part because she says she, quote, hates needles, unquote, and in part because her brother is not always available to help her with her injections. Checking her iron stores finds that her TSAT is now 18%, so that's below normal based on these guidelines, and her ferritin is at 90 nanograms per mil, which is also below guidelines, the lower limit and the guideline recommendation being 100. Her diabetes care is also deteriorated with a hemoglobin A1C back to 8.1%. And so the questions now are, what would be the appropriate next steps for hemoglobin care? What should we do? And I'm going to turn first to Dr. Davis. What do you think, Dr. Davis? Is her iron deficiency because of her diet? Would you consider having her hook up with a nutritionist? She also has a poorly controlled hemoglobin A1C. Should she link up with a diabetes educator? How do we navigate this whole family support problem? There's complexity because her brother isn't able to support her as well as we might have desired. And the VNA tells you that she's also having difficulty with payment of her medications and insurance issues. What are you going to do here? What are your thoughts?
Well, again, looking at where the patient is and not where the ideal treatment would be. It is very difficult, or it has been in my experience, to be able to get the ESAs as a home medication. I was pretty impressed that she could get it for 3 months. She clearly is iron deficient again and will continue as she continues the ESAs because we know that they increase the utilization of iron. A nutritionist would be of questionable value simply because the availability of a nutritionist and the ability of the patient to change her diet or the patient's willingness to change her diet. I would attempt to get her to restart the oral iron with a laxative or usually a bulk laxative. I think that we need to involve the brother in this discussion. He does not live far, and why is he unable to give a once-a-month injection? That would be a bit concerning. We need to point out to her that with better diabetic control, her foot ulcer is getting better and she is feeling better. And again, the patient's voice needs to be heard in all of these decisions.
Great, thank you. Do you think that also adding in other members of the team into the conversation, like, for example, a social worker who can, I've always found that social workers add a huge amount of value because not only are they, they have specialized skills, but they also have a lot of common sense. They often are rooted within the community, but they also have an understanding that at least I find very challenging of all the complexity related to insurance and payments and so on. What are your thoughts on that?
Well, definitely would use the healthcare team, depending on what's available. Again, we don't know what actually is available to HB, but the social worker is critical in planning care for a patient and implementing it, because they do understand, as you said, the intricacies of the social support systems and can often find avenues that we as healthcare providers are not aware of, and resources. So I think if we had a dietitian or a nutritionist, and if we had a social worker available, they would have been included from the beginning.
Dr. Meaney, you made a number of excellent points in your presentation. I just wanted to ask you, this is a challenge that's common to many, many, many different patients. And this issue of interprofessional care, I tell my my junior colleagues that really healthcare now is a team sport. It's not about one person. It's about a team of people, and getting this team of people to work well in a high functioning way. Do you want to spend a little bit of time talking to us about the opportunities of interprofessional care? Should this have been considered at the beginning? Are there examples of structured care that are available, models that we can take advantage of as we grapple with problems like this patient HB?
Yeah, I mean, I think excellent points. And I mean, as Jane has mentioned, there are a number of health professionals that would certainly be well suited to help this patient: nutritionist, diabetic educator, social worker. And I think that really highlights the need for proactive implementation of multidisciplinary care teams in chronic kidney disease patients, and in particular when they suffer from anemia. Challenges to that approach are that these team members have to have a well-defined role and well-delineated responsibilities. And it really has to have that sort of patient-centric model where everyone's trying to achieve the best outcomes for that particular patient based on their healthcare goals and healthcare needs. And that with that combination of well-defined roles and a patient-centric approach, that leads to the best outcomes for the patient. Unfortunately, there's not been an ideal model that's been published, at least in terms of the CKD or CKD-anemia space. But those to me are the two key things: a well-defined role and patient-centric approach with the various interprofessional members of the team.
And I think we all agree, Dr. Davis and Dr. Meaney, when you see it work well, it works really well. And the benefits are really meaningful. Patients not only feel better because they're getting not just the laboratory value being corrected, but they're really getting supported. Other aspects of their care improve. But then it's also important for the families that can then see their loved one, potentially, sadly progress, but at least feel that they're supported, so that at least outcomes can be optimized. I just want to say thank you to both of you, Dr. Davis and Dr. Meaney, for an excellent series of presentations, and in particular for the dialogue we had with respect to each of the cases. I also want to express my thanks on behalf of this faculty to Creative Education Concepts for really organizing this educational activity, and to GSK for the Independent Educational Grant. Thank you again. Goran, is that good?
That's perfect. Thank you so much.
Anything you want us to do again?
Guys, Aaron,
No, I think it was
Susan,
really
Jessica?
good.
It's good. Cool.
Goran, I had problems with the slides advancing. I don't know if I have a heavy hand on the mouse or not, but can you fix that?
Oh yeah, that's easily fixable. Yeah, that's no problem at all. Yep. No
And of
problem.
course, let me just say, Erin and Goran, and of course, Calvin and Jane, I really loved working with you guys. It was really very, very good and very efficient. I'm always available. If you want to redo something, you can get me, anytime. I'm happy to just jump on a Zoom call and re-record anything or any aspect of it. But I just want to say thank you again. Take care.
Thank you.
Thanks,
It's my
Dr.
pleasure.
Thank you.
Thank you.
So I think we only need Dr. Meaney now for.
Yeah, we'll just go back to those few.
For your section. So let's go back. I think you have maybe 5-6 slides.
Before we begin on that, I'm going to look again. I was a little concerned. Calvin and I had different values for the TSATs and the ferritins. I thought I was using the most recent KDIGO guidelines. I have them. If needed, would it be possible to record one slide?
I know that there were different values, but I think that they're showing different things. So like yours was showing the definitions of iron deficiency,
Okay.
whereas mine is showing the sort of treatment thresholds for using iron. So, and they're different. That's, I think, part of the confusion in
Okay,
clinical
but-
practice is they're different definitions for deficiency versus where do you treat to.
But you're not finding that contradictory?
Yeah, it might be better for the audience if we were clear about them. Yeah, I get what you're saying.
I have the guidelines because I did a program on anemia, and I'll look at them again. The other thing is the potassium value in the labs. He read as milliequivalents, and it's not listed as milliequivalents. Does that need to be fixed?
Yeah, I think it was just on one of the slides in the part 3 of the case.
Right.
Part 3. Yeah. Maybe it was part 2.
Well, is this something that we can just fix by changing the slide? 'Cause
Yeah.
That's
Yeah.
easy.
Yeah.
Yeah.
That's easy.
Patient
If
case
it's-
part 2 under the labs, the second to last line says potassium of 4.2 grams per deciliter. The units there should just be milliequivalents per liter. Let me go this one. So potassium, the units here should be milliequivalents per liter. So it could just get changed on the slide.
Okay, Aaron, if you don't mind, just make that note and send me the fixed version, and I'll pop it in while editing.
Okay.
That's no problem. If it doesn't require like verbal re-recording on a video saying these figures, yeah, we can easily swap out slides, and that's no problem.
Aaron, I'll get back with you later today about the iron. I'll get back with you and Calvin to see where we want to go with that.
Yeah,
So,
let me know.
are y'all done? And Calvin, thank you very much. You did an excellent presentation. Second time we've worked together, the first time I've seen you.
Yeah, the last time was all on paper.
Yes. So do y'all need me anymore?
Susan, Aaron, I think we're okay with Dr. Davis, right? We don't.
Yeah, I think so. Thank you so much. This has been great. We appreciate all your help with everything.
Well, thank you. This really has been enjoyable, and I appreciate the opportunity.
Thank you so
Great.
much.
Thank you.
Thank you, Dr. Davis.
Take care.
So
Hope your day
Cal,
gets better.
listen, that was just the start of it. It's been one thing after another. Been ridiculous, but no more smoke alarms going off.
That's right. And it's Friday.
Right. Well, thank you. And thank you all very, very much. I hope to work with you again.
We do too. Thank you.
All right.
Thank you.
Take care.
Bye-bye.
Bye-bye. All right, Dr. Meaney, this is where you begin all to this
Yeah,
slide?
and I
Perfect.
believe Dr. Singh read through this and sort of introduced it. So I'm just going to start I'll advance the slide and just start right into it.
Perfect, great. Would you like me to count you in, or you can just sort of count down in
Yeah.
your head, 3, 2,
Yeah, I'll
1?
just wait a
and
few
stuff?
seconds and then go.
All right, cool. I'll let you do that.
Thank you, Dr. Singh. This to me is really the framework of a multidisciplinary care team in the chronic kidney disease space. And my favorite line here is teamwork makes the dream work, right? The more healthcare professionals that we can have providing patient-centered care to our chronic kidney disease patients, the better. And this is not an inclusive list. So this includes our nephrologist, nurse, dietitian, nurse practitioner, physician assistant, pharmacist, social worker, again, all working in a patient-centered approach. There are certainly other healthcare professionals that will fit into this, and depending on the patient populations, maybe more or less needed. But these are ones that we commonly encounter in our team-based care of CKD patients. These CKD patients are highly complex from a medical perspective, have reduced health-related quality of life, have poor health outcomes. They are very well suited to this multidisciplinary treatment approach. The optimal structure of a team and which professions are involved is not well known and not well described, but the key component here is patient-centered care from an interprofessional team. And that leads to great outcomes. And that's really the next point that I really want to make, is that multidisciplinary care in CKD broadly, not specific to anemia in CKD, but broadly in CKD, is associated with improved kidney survival, a higher rate of guideline-directed medication therapy, reduced all-cause mortality, cost savings, and a slower decline in kidney function. So they do improve the care of these patients. They do improve their outcomes. Specific to anemia, multidisciplinary clinics are associated with better hemoglobin target attainment, lower utilization of ESAs in terms of the dose used, and that leads to significant cost savings and potentially reduced risk of adverse effects like those that we talked about in past slides. And so really, I think that because of health disparities that we know exist within CKD and in anemia of CKD, that multidisciplinary team-based care that's patient-centered is best positioned to advance the health equity of these patients. And I like to present the term pharmacoequity. It's a relatively new term that's been coined by Dr. Essien, which is that it's a health system where all patients, regardless of race, class, and availability of resources, have access to the highest quality evidence-based medical therapy indicated for their condition. And that is really what my goal is as a pharmacist member of an interprofessional team, is working to achieve that for all of our patients, the best medication for each individual patient, regardless of their ability to access care, their race, their class, their availability of resources, et cetera. And I think that's something that the team should really work towards as a goal.
Thank you for attending this edition of CE Conversations. We hope it has been impactful for your clinical practice and, most importantly, for the patients you serve. Please proceed to the link in the show notes to complete the post-test and activity evaluation to claim your CE credit.